Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. I'm happy to be back at it with you.
Oh, it's always good. It's always good. I feel like it's ripe time for a podcast episode, especially one with our friend and hand therapy expert colleague, Macy.
Welcome,
Hi.
Macy.
Hi, thank you so much for having me back again.
Well, it's not like we had a choice. I mean, when the people clamor for a guest, we have to deliver.
Man, that is so flattering, but I'm glad to be here.
Macy, are you podcast famous?
Dr. D, don't make me embarrassed. But yes, I recently have been identified from a surgeon in Chicago, which I was very flattered by. And yeah, I appreciate the publicity.
We're happy to make you even more famous than you already are.
Thanks.
Absolutely. And Macy, did you know, and you must, because I think you maybe jumped in the shower before the episode, but we do put this on YouTube. We are going to video. So thank you for
Oh, well, that's good because my hair is wet tonight, but sorry about that.
no, no complaints. I'm just telling you, YouTube is growing in popularity, and we have our channel, and so hopefully you're okay with that.
I actually did not know that, but I'm fine with it.
Wow. Informed consent, huh, Chuck? Is that how it goes?
That's how it goes. So I want to share with you guys, I just did a little mini mission trip, and it was pretty great. Lindley Wall and I work with the World Pediatric Project, which is really a fantastic group. They are based in St. Louis and Richmond, but also expanding across the country. And we did something a little different. It's a little crazy, but I flew down with Eric Gordon, one of our pediatric partners, along with a nurse, Melissa, and a hand therapist extraordinaire, Lauren, and also an orthotist. And we flew down for the weekend to Barbados. Now, Barbados is not next door, but we made the trek. We left super early Friday morning. We saw a ton of patients on Saturday, and we flew home on Sunday. So it was a little whirlwind, but Barbados is an amazing island, and there's a lot of unmet need. And so it was really great. And it was super fun to work closely with Lauren. We basically, the two of us were in the same room from a little before 8 a.m. till about 6 p.m., just seeing patient after patient after patient. So it was awesome.
You're talking about our Lauren Meone?
I am.
Oh man, I did not know she was there. That sounds great.
Yes, it was perfect. And then she embarrassed me on our runs because I can't keep up with her. So
that sounds about right. Is it your knee arthritis or your Achilles tendonitis this time?
Well, how much time do you have? I'll tell you about all my ailments. You youngsters don't know what happens after 50.
I'm just kidding.
Chuck, I did leg day over the weekend, and I completely regret it. Really need to stop listening to my wife that I need to work on my legs. But that's my current ailment.
Yes, indeed. So
Chuck, two things.
Oh,
two things.
All right.
One, how was it hanging out with Rihanna? And then two, what are the greatest unmet needs you think, and from a just pure pathology perspective, what conditions were you seeing down there?
What was cool about this trip is the WPP partnered with, it's called the Sandy Lane Charitable Trust. And for anyone who knows anything about Barbados, Sandy Lane is a super high-end hotel where we did not stay. But we did stay in an associated villa. There's a golf course and there's beautiful homes, including, I think, Rihanna's and Simon Cowell's. So it was really nice. And we did have brunch invited by the head of this trust there. And so it was really cool. What we predominantly saw were patients with untreated upper extremity CP and birth brachial plexus palsy. And I think we need to just streamline things because we didn't see a lot of congenital and we didn't see a lot of trauma, which we could have and should have. Maybe we needed one more day of clinic. And the whole goal of this trip was to set things up for more of a surgical trip in the future. So that was great. I'll tell you, Chris, I saw one thing that will make you excited because we have to always talk about nerve. I understand the ground rules. And so basically, and I'll give a shout out to Scott Cozen, he had seen one of these children and the child had no active elbow flexion. And I don't know exactly what he did because I didn't have the opera report, but essentially he did some type of intercostal nerve powered transfer, and the kid had like incredible active elbow motion. It was awesome. Even I, who don't love any of that, was super impressed.
Well, I think it goes to show you, I mean, intercostals are, they're reliable transfer. They're a pain in the butt to do. They're not always an option. They're less sexy than a double overland or double vesicular transfer. But, you know, even the pooled analyses in the literature still show they've got pretty good success rates, a lot better than some of the other stuff we do on a routine basis for brachial plexus. So actually, since we have Macy on the episode, I wanted to ask Macy, what do you think are the tricks to nerve transfer reeducation for intercostals? I mean, clearly it's a little bit easier in the child, I would think, in terms of them figuring out how to use it. But how do you approach that in an adolescent, in a young adult, or an older adult?
I agree with you about the children. I feel like for them, it's a little bit more intuitive. I don't see a ton of that with kiddos because I feel like a lot of times formal therapy may not be as crucial in terms of consistent therapy as some of the adults. So they kind of just figure it out. But I think for the adults, teaching them a lot of exercises in supine and kind of interweaving nerve reeducation with some bed mobility type things as you're already laying in bed, and incorporate some exhalation, some abdominal stuff, breathing techniques in terms of coordinating that with elbow movement as well.
I remember when I visited David Chuang in Taiwan, where they used both intercostals routinely, but also the phrenic. They would just have their patients go on hikes all the time,
perfect.
all sorts of aerobic activity, especially in higher altitudes.
That is cool, but I'm gonna say that we're not gonna hijack this episode and talk about nerve. I gotta put my
Okay, wait, I got one thing to add though. So since our last episodes, we've had some great listener email. And this is one where I think we could piggyback on a prior episode about the one where we talked about nerve injuries after carpal tunnel release. And I just want to read one question from a listener, and maybe you could give me your thoughts since you taught me how to do a carpal tunnel release.
Okay, I'm a little nervous, but shoot.
And then we'll jump in with Macy and we'll talk about our therapy episode. So Brad Hyatt writes us. He's an orthopedic surgeon, says he loves the podcast. So thank you, Brad, for listening and for telling your friends and for emailing us. He's an orthopedic hand surgeon practicing about 5 years. He said, it's with special interest I listened to your latest episode. The day before, I had undergone a carpal tunnel release myself. Fortunately, I underwent a wide awake procedure by a trusted colleague and friend. Everything went smoothly. I'm wondering if you might be willing to share your thoughts on the cause of the nerve injury that you described. One of my least favorite parts of an open or mini open is what I call a controlled glide technique to release the proximal aspect of the TCL/distal volar antebrachial fascia. All the technique articles and videos describe this as being performed under direct visualization. There are times when this glide is not quite directly visualized. I have occasionally extended the incision proximally, but dislike the prolonged healing and wider scar when crossing the wrist crease. I have been tempted to perform a scissor glide without 100% visualization. This can be so routine and seems safe, yet the consequences of an error can be catastrophic. I can't help but wonder if this is what happened in the case you presented. I'm interested to hear your thoughts and any tips or tricks for the proximal release. So Chuck, can you help enlighten Brad?
Well, I don't think I could have said it any better than Brad wrote it. I really like how he outlined that. I do agree that I would expect that many, if not most, of the nerve injuries with carpal tunnel are related to scissor, sliding or gliding or whatever you want to call it, which also comes to the point of an endoscopic release, because that's what you're doing with an endoscopic release. But Brad is right. You have to visualize. So I was taught to do a carpal tunnel by Tom Kiefaber in Cincinnati, and he really uses 3 instruments and 3 retractors, and that is 2 Cineraches and a Ragnell. And I love his technique. And as Chris, as you know, 2 of my partners who also trained in Cincinnati use exactly the same technique. And when we dissect proximally, we create simply a little box, 3 sides of a box, where 2 of the retractors are, one is put in from the ulnar side, one is put in from the radial side, and one is put in from the volar side. And so you have basically 3 sides, and the bottom of the box is the antebrachial fascia or proximal transverse carpal ligament. And then you have visualization. Now, I think in the right setting where you have visualization, occasionally I will slide a little bit, but I think, you have to be super careful. And you can flip that around and go the other direction. Now, I never slide just aiming distally. I think that is controlled cutting. And I think, as I recall from your previous description of the case, it was a distal, I think it was a distal injury of the nerve, but I think the most common injury, your case was proximal, but as I recall, the most prominent injury with carpal tunnel release is distal. It's the common digital nerve to the ring and middle. So I think the lesson is don't slide, even if 99 times out of 100 it's safe. That's my take.
Yeah, I agree with you entirely. I mean, it's just such a surgery that should go well. And I think anytime you introduce any variability in that, like I trained with somebody else who did the slide technique in residency, and it always worked then, but what if it doesn't? And, I think I agree with Brad and what you were saying, Chuck, that was probably the cause of this injury. Did another case pretty recently with, I think I did like 4 revision surgeries in the same day. And I don't know what I was thinking when I booked them, but it was an incomplete release. So it was the other side of it. It was that same tissue that wasn't released. I use the Kiefer box technique. I modified it a little bit, but I think it's no sliding, all under direct visualization. Because if your tenotomies catch on something, your tenotomy blade isn't sharp, and you're pushing more than you want to, you're going to catch something in your in the bottom tine of your tenotomies, and that could be very, very, very bad. I remember reading an article that was written by a group of hand therapists who mentioned the potential risks or the advantages, the pros and cons of open versus endoscopic carpal tunnel. And yes, the endoscopic patients, anecdotally in their experience, tended to get back quicker. But what if you have that one injury? That's a catastrophic and devastating injury to the nerve. And you clearly don't want to be that one patient, even if it's less than 1%. If you're that one patient, that really matters.
Yeah, well said. Macy, have you dealt with a lot of, or seen, hopefully not many, have you seen many median nerve injuries with carpal tunnel release?
Yes, I have 2 on my schedule right now. Unfortunately, they were both endoscopic, and both of the surgeons, unfortunately, lacerated the ulnar. One of them was an ulnar nerve, one of them was a median nerve. So they've had a much more complex journey. So in that particular case, sure, I've met them and we get to know each other well because they have a long journey ahead of them. But in more of the standard, are you talking open or endoscopic? I'm sorry.
Either way.
Either. So endoscopic only if there's a complication, for sure. Open, not often, but typically if they have a little bit more of a high demand job or they're concerned about strength or getting back to a particular activity or job, or if they have a particularly high proclivity for scarring.
Well, Brad, thank you for sending in that email. And if anybody else has some thoughts about the proximal release technique, please, please, please email us. Let us know. Chuck, did you have something you wanted to add?
Well, thank you to Brad. We always welcome comments and questions. It's just great fodder for discussion. We are this close to what you're all waiting for. That is Macy expounding on the CMC joint, because that is our topic. But Chris and I are doing something super fun. We will both be in London for the IFSSH, and on Wednesday, late afternoon, I believe it's 5:30 or 5:45, we're going to do a live taping of the upper hand at the IFSSH. So we hope that if there's a few listeners who might be willing to join us, Chris is going to bring some swag, I hope, and it'll be super fun. And it might just be Chris and I talking in a big room, and that's fine too.
It'll feel like conference many years ago. But yeah, it'll be really fun. I think if anybody wants to join us, well, it's going to be in the meeting program, and we'll send out some promos and stuff. I think it'd be great if you guys wanted to join us, show us some UK and international love, and pick up some swag. So, and Chuck will be signing autographs on any textbook that you bring him that day. Promise.
As usual. All right, Macy.
Yes.
We want you to teach us tonight, and honestly, this will be an education for at least me. I don't want to speak for Chris, about how you conceive of care of the CMC joint. And I think we should really probably focus primarily on non-operative care of CMC arthritis, the role, your success, what you think is important. And then if we have a little time, we can also discuss how you think about post-operative care of CMC joint after various surgeries. So is that you up for that?
Yeah, that sounds great.
Okay. Which patients, let me give a case scenario.
Okay.
So we have a young, vivacious 54-year-old male, older than me, who has Eaton stage 2 CMC arthritis, so not terrible. His no dramatic subluxation of the CMC joint, no contracture. His MP joint is stable. This is his dominant hand. He says that, sometimes he's okay. It does seem to flare now and again. Opening jars is tough. He has to ask his kids or his wife to help. And he just wants it to be how it used to be. And so he was sent to you. What do you do with him? What do you tell him? Can you fix what ails him?
It sounds fun. Okay. First of all, I think this patient has the perfect opportunity to actually improve conservatively in therapy with this diagnosis. First of all, it's a moderate severity, as you described. He's a guy. Anecdotally speaking, I just feel like men do better. They have stronger hands, stronger joints. It's his dominant hand. So I would, if I'm in your clinic, I would write on the referral the following. Please see in therapy 2 to 4 times or as needed for up to 8 weeks, etc. And then I would not necessarily say strengthening. I would say, please instruct in activity modification, joint protection, education, orthotic needs as needed. And then what I would write as a Millikan therapist would be in stabilization exercises. So in a way that is considered strengthening, but it's not strengthening like one would think with weights or bands or therapy putty or anything like that. So anyway, I would meet this gentleman on the very first day, get a history of how long this has been going on. Have you had any injections? What are your goals? What hurts? And then I would evaluate him. If he doesn't have any obvious deformity, no subluxation, he doesn't have a zigzag posture, he doesn't collapse at the MP joint with pinching, I'd go straight into showing him the anatomy book and kind of highlighting the beak ligament and what happens and kind of what the posture that we're trying to avoid. And kind of, I always kind of show this picture of like advanced CMC arthritis of like the zigzag. So I'm like, this is what we're trying to avoid. You have really good opportunity now to prevent it. And as a hand therapist, we all know that I can't take away your arthritis, but I can offer you something. So since the problem is, your ligament that keeps your CMC joint stable, I kind of describe it in layman's terms, like it's not really holding everything together as tightly. And so when you pinch something, that's where you feel pain. I can't tighten up your ligament necessarily, but I can potentially fabricate you a splint that's going to keep that CMC joint somewhat suspended, keep you from having repetitive motion. And really it's for pain relief. It's for pain relief. It's to keep your thumb in a good position. And in theory, I guess it would be to, tighten up your ligament, I guess, because there's no magic exercise that tightens ligament short of immobilization. So that would be one of the main things I do is educate them on what a splint can do. I don't ever force that on them. I explain, this is what it could do. Feel free. I can make you one today or think about it in the future. Do you have a question? Sorry.
Well, yeah, I think we can break it down and ask kind of what you've said a lot of really.
I know. I'm particularly passionate about this subject, so you got to stop me. So
Chris, you go first.
I'm so happy that we have 2 people on the podcast that are experts and passionate about thumb CMC arthritis, Macy and Chuck. So when you talk about joint stabilization, what exactly does that mean? And then, you mentioned, what was I'm trying to remember the other term that you used. I thought that was interesting. It was regarding.
Was it activity modification?
No, I think I understand that one. It was one of the first things you stated.
Joint protection.
Joint protection. That's it. So tell me about joint stabilization, joint protection. what those are and how they're different.
Great. So joint stabilization is what everybody thinks of when they think of therapy, physical therapy, like occupational therapy, exercise-based treatment. So the classic pattern of deformity that we would see would be CMC flexion, MP joint hyperextension. And so we explain that this is maladaptive. This is not going to contribute to a healthy posture long-term. You're going to have pain. So we want to try to encourage the opposite motions. So we want to help encourage CMC extension and MP flexion. And so there's an exercise, and if this is truly going to be on YouTube with my wet hair here, I can demonstrate it at the camera. So I can make my thumb collapse, if you can see the lighting. My CMC joint flexes and my MP joint hyperextends. It's somewhat mild. And so a lot of people come into the clinic and that's what they do. And then I always start with saying, okay, make an O with your thumb and index finger. And then sometimes they can't do it. It looks like a D or like this, and they cannot rotate that first metacarpal to make an O. And so I try to help encourage them to work on this motion, whether, actively with what we call in the therapy lingo, like a place and hold, where you passively pull your CMC joint back into extension, let go and hold it. A lot of times that's very, very difficult for patients to do. An exercise is also to hold on to a pen, pretend like you're writing, and that helps encourage really good mechanics of the CMC joint. So anyway, I explain, make an O with your thumb and index, transition that O into a C, O into a C, and it really helps activate, EPL, EPB, all those things that are helping bring that CMC joint into extension. And then trying to help keep their MP joint flexed. And then I always say, so why does this matter? Why are we doing this exercise? This seems silly. And then we have a little booklet at our clinic that kind of shows somebody's thumbs doing various things, opening a jar, squeezing toothpaste, with good posture and with bad posture. And we go through it together in a booklet and say, like, which one looks good, which one looks bad. This exercise matters because long-term, it's going to help encourage more healthy thumb mechanics. Like I said before, I can't take your arthritis away, but in a way, I can kind of re-educate your muscles and beef up the muscles that surround the joint to give some sort of dynamic stability to the joint so you have less pain long-term, to maybe prolong your need for an injection, prolong your need for surgery, just give you a little bit more of a healthy thumb posture. So anyway, our exercise handout says, make an O, make a C, lift your index finger. That activates your first dorsal neuroosseous. So we're trying to really activate, your opponents, your first DI, working on that nice, healthy posture of the thumb.
I love that. And I assume this is an hour-long visit, your first visit with them.
Depends on which therapist you're talking about. For me, it would be an hour. Sometimes it can be 45 minutes, depending on if I have to make a splint or not. And some patients just kind of get it quickly and they really, really understand the anatomy you're talking about. Sometimes patients, you can tell they're not really grasping it all, and you can have to just be a little bit more simplistic with your language. But definitely 45 minutes to an hour.
So describe the splint that you custom fabricate for patients. And then I guess more importantly, teach Chris and I how you instruct the patients on where. When should they wear it? How long should they wear it? When should they not wear it? I'm sure we all have our own anecdotes, but just tell us what you tell them.
So I will fabricate a very low profile, I think, thumb spica splint with the thin material that has aerated holes in it. It's not as robust as what I would, make for somebody that had a wrist fracture. And I fabricated on them and kind of push their CMC back into a little extension, a little bit of palmar abduction, and then MP flexion. The wrist and the thumb IP joint are excluded. And then it kind of mirrors that same shape of the O that we've been trying so hard to, work on with the exercise. And I often will say, wear as much as you can tolerate for 2 weeks, especially if they had an injection. And then after that, as needed. If you have pain only at work or while you're doing things around the house, wear it during those activities to prevent, repetitive thumb movement, to help give you a little bit more support. That would be my preference. a lot of people can't tolerate it all day because it is somewhat restrictive, but I always say it's restrictive intentionally. So some people can only tolerate wearing them at night. That's still a win for me because they're getting some sort of support, but I would probably, go from 2 weeks full time, except for hygiene, or if you just need a break, to just during functional daily activities and then just PRN.
How do you have them?
Go ahead.
I was gonna say, how do you have them alternate between something like that custom orthosis? When you say thumb spica, I'm assuming you mean something that's forearm based versus can it be a hand based splint? Or I've seen patients come in raving about comfort cool braces, push braces. What's the role for those kinds of things?
Sure. So I actually only fabricate the forearm based ones if they have carpal tunnel as well for nighttime, or if it's a post-operative case. So in the standard CMC conservative management, I always make it hand-based. The comfort cools, man, you're asking the wrong therapist, because all my colleagues adore them. I think they have a role, but I'm not a huge fan of them. They're more functional because you can move better, but they don't support the CMC as well. And patients anecdotally say they don't have as much pain relief, but they have more function. So, and that makes sense to me. But I will give them out on the rare occasion if somebody needs them for yoga or for cycling or for gardening, and they just can't use their custom plastic one because it's too restrictive. I wish we had the push ones as you describe. We don't. I actually like those pretty well for the CMC joint because I feel like that helps support them and pushes them into extension a little bit, but it doesn't do anything for the MP joint. So if they have an unstable MP joint that collapses anytime you pinch something, I don't necessarily think the push splint is for that person.
I love this. We just get to pimp you with questions. What is the definition? Because all of our listeners may not know, and I certainly can always use a refresher. What is the definition of and the importance of, if any, iontophoresis in the care of the CMC arthritic patient?
So that is not a modality that I practice typically. And I don't know if it's because it became a little bit more, I don't want to say antiquated, but a little bit more in the past when I started practicing. But there are some physicians that request it with their patients. I'm going to be completely honest and say I don't have experience with this, but it's basically dexamethasone infused into the thumb joint, I believe, to help decrease pain. But the instructions are to do it 3 to 4 times a week. I work at the Millikan Hand Center, which is in the middle of the city, and there's so many patients that I have where our biggest deterrent for therapy is transportation, parking, getting there from work. So many people, like, it's such a difficult thing to get people to come sometimes, that to have them come 3 or 4 times a week for that would be difficult, I believe. And so more frequently now in 2022, I feel like they have more portable units where they would take them home and just do that as an independent therapy at home. But again, I want to be really honest and say I don't have a ton of experience with that modality.
And this is ultrasound.
Yes, ultrasound guided steroid. Yeah.
Chuck, do you know one way to infuse dexamethasone into a joint one time?
A big old needle.
You also asked previously, Dr. D, about joint protection.
Yeah.
We talked about joint stabilization exercises. Joint protection isn't as fancy as that. It's not rocket science, but it's a thought process that a lot of people may not have. So some people correlate therapy with exercise-based treatment, a lot of no pain, no gain type mentality. And so when they come to therapy for CMC arthritis, they think that's what it's going to look like. And you kind of have to re-educate them that, it's not that kind of thing. Joint protection, there's some strategies that we just want to help you understand. In the first, we have like a little bullet point handout we give our patient with like the basics of it with some photos. So the first one is to respect pain, or always let pain be your guide. If you're doing an activity that causes a lot of base of thumb pain, probably not the best idea. It's not the kind of thing that's going to make you stronger. And that seems like a very simple thing to understand, but you'd be surprised at how many patients don't know that. Other things that we instruct them is in the use of modifications and adaptive equipment in the kitchen. So like different types of ways to open jars, whether that's with a gadget or like a device or just a technique, the way you grip it, different types of knives. We talk about the importance of using larger joints as opposed to smaller joints. So if you think about your thumb CMC joint versus your elbow or your shoulder, it can withstand so much more force as a shoulder. So like when we talk about taking groceries in from the car, so many people will put 7 bags in one hand, 7 bags in the other because they don't want to take 2 trips. It seems simple, but telling them about the importance of like having a big shoulder bag and stuff, all your groceries in there. And again, it's I guess a little bit more of a simplistic type thing to educate them on, but we've had good receptivity to that type of education in this population.
Next question. I feel like I'm the attorney. What is the role of paraffin wax treatments for CMC joint arthritis, like dipping your hand in the thingy and leaving it there for 20 minutes?
Dipping your hand in the thingy and leaving it there. That's the very technical description from our full professor.
So I definitely think it has a role, but not because of the wax medium, but because of the heat. So that can be warm towels, a heating pad that you plug into the wall, warm rice that you put in the microwave and lightly grip, paraffin, whatever makes the patient feel better, I'm all for. I do instruct patients in heat therapy for this particular thing, but I'm always very honest and say, this isn't going to make your arthritis go away. You can do it once, you can do it 5 times a day, does not matter. But it's not something that I would have somebody come to therapy for once or twice a week just to do paraffin. I would instruct them how to do it using a home unit, or if they were already coming for other things and they wanted to do it, then great. But I mean, I think we all know that it's not going to change the course of their arthritis progression, but if it helps the patient manage their day a little bit better, I'm all for it.
Macy, without naming names, what are some of the misconceptions that you have to correct when patients come in? Perhaps they've seen a hand surgeon either at our medical school or somewhere else. What do you have to unteach?
That they need to come once or twice a week for 5 weeks, because I feel like that would be, I don't have enough to teach that patient that often, I would say. So I would feel fraudulent billing somebody's insurance that frequently for this diagnosis if I didn't truly believe that I was making an impact. So the frequency at which the referral is written, and then if it says something like strengthening, work conditioning, work hardening, or something like that, where you think strengthening of the thumb. So a lot of people have like therapy putty where they're just pinching it to strengthen their thumb. And sure, that's going to strengthen you, but it's going to make you much more painful. So what's the point of a really strong thumb if it hurts so bad you're not going to use it? So those would be my things.
Right. What I do want to share one paper, which I literally think is the only, well, there's a couple of papers, but what other modalities do you believe are helpful, or have we hit them all?
I would say our go-to is heat, warm rice or paraffin or heating pad, not cold. I mean, if they particularly find that helpful for them, great, but most people don't like it. Electrical stimulation, no. I don't have a lot of experience with patients using a TENS unit on their thumb, but if it makes them feel better temporarily, then sure. Modalities, ultrasound, no evidence to suggest that's going to do anything. I think we've hit them all.
Chuck, before you jump into that paper, what do you tell people to do at home, Macy? You mentioned the exercises, making an O and then a C. What else do you teach them, and how frequently do you ask them to do it?
So the exercise, I would say, I write on the top of their paper, this is a lifelong exercise. If you do it once today, 0 times tomorrow, and 7 times the next day, great. This is something to have in your back pocket to pull out throughout the years. That's the only thing I have them do like on a regular basis. Well, with those parameters. But the other things, being cognizant about the thumb posture and a lot of the joint protection techniques or the heat all day, every day, they can incorporate those things into ADLs and that type of thing. So it's not the kind of therapy that you think of, okay, I have my exercise folder and I have to do these 4 times a day, and then I do 10 reps and then I hold for 5 seconds. Like, it's not like that. It's more, come to this session for an hour. Let me educate you a lot about what this looks like and how to incorporate basic strategies into everyday life, whether that's cooking, driving, brushing your teeth, etc. So it's not the sexiest treatment, I would say. And I might treat this diagnosis very differently than some of your listeners here. But I'm just here for my insight, I guess.
That is why you are here, because we value your insight and you feel passionately about CMC.
I do.
All right. So my favorite paper in the literature on this topic, and again, I said there were a couple, there are, but most of them are like meta-analyses looking at outcomes, and they really aren't that helpful. Just like, honestly, the surgical papers aren't that helpful because every, in my opinion, about every surgery does pretty much the same, which is good. But not that, it doesn't help distinguish. So this is a paper out of Rotterdam. The first author's last name is Tsehaie. I'm not going to try to pronounce it. But the title of the paper is Outcome of Hand Orthosis and Hand Therapy for CMC osteoarthritis in a Daily Practice, a prospective cohort study. It's a well-designed study. Rotterdam, I visited there, part of one of my traveling fellowships. I've been back a couple of times. It's a really good group of plastic surgeons primarily that really kind of get hand surgery, adult and pediatric. And bottom line, just to cut to the chase, is this study had a 2.2-year follow-up, and the magic number is only 15% of patients that were sent to therapy ended up having surgery in that time frame. Just pretty remarkable. Pain improved primarily early on. The MHQ score, Michigan Hand Questionnaire, was basically flat over the period of the study. And I think it has to do a lot of what we just heard from Macy. It's about teaching patients what they can do, how they can manage their pain. And I think the lesson for me is just don't be so quick to run to the operating room. I'm a surgeon. I love surgery. I think it can be very helpful. But many patients will like the concept of trying to avoid surgery, trying to avoid injections. And I do recommend this 2018 study for those of you who are interested, and I'll put it in the show notes as well.
Thank you for educating us on that paper. And we don't have to get into this, but I'd be curious to know how they operationally define therapy. Like, does it just go to therapy, yes or no, or what was done in therapy? I'm not really sure if you know that, but it's something that I would be interested in looking at in the future.
Yeah, so basically they all got custom-made or a prefab orthosis. They had 2 sessions of hand therapy per week, which is what you said you didn't like to do, for an average
it depends on what's done.
an average of 25 minutes. Basically the therapist controlled what was done and when it was done. Some patients only got the orthosis. Some patients, went over a course of multiple weeks. And so it sounds like a fair amount of variability in what exactly they did. But that number is remarkable. It's remarkable that only 15% converted to surgery after seeing a surgeon for CMC arthritis, and 2 years later, only 15% had surgery. It's great. It's fantastic.
What do you think your number is? What percentage do you think your patients that you see sent to therapy then cross over to surgery?
It's just, I don't know the answer to that question. The ones I know are the ones that come back for injections until they fail. And my pattern, I assume, is like everybody else's. The first injection, and especially in a patient who doesn't have terrible arthritis, is good, maybe 9 months or a year, and then it slowly declines. And when patients are seeing me every 3 months for an injection, they get tired of it and they schedule surgery. Is that your experience?
Yeah, but I mean, I feel like the 50% feels about right to me. But our practices are at very different points in maturation. So I think, I remember, and I've said this on the pod before, I mean, my first year when I was in board collection, I didn't do any thumb CMC surgeries because my practice was just starting, and it's not what I jumped to right away. And it took a while to even get a reasonable clip. And I was certainly not one of the high enrollers in your study, mainly because I didn't do a lot of it and still don't do a ton. And maybe that's just the nature of the practice I have, because I see so much nerve and other stuff too. But I'd like to think I have a pretty robust general hand surgery practice. And I think 15% feels about right in terms of conversion. Maybe it's even a little higher than what I see. Again, I mean, I'm not as passionate about this in terms of like jumping to the OR, but I'd like to think I have reasonable indications.
So I've worked with both of you in your clinics, and Dr. Goldfarb, I know No, well, either of you, if there's a patient coming in for like routine injections, obviously like they've probably been down the therapy route before. That's not going to be somebody that I know that I need to go write a referral for. But do you feel like somebody coming in as a new patient, never been to therapy, kind of that same case you described in the beginning of this podcast, would both of you 100% send that person to therapy? Maybe like depends on what your mood is that day, depends if you have a therapist in the clinic. I'm just curious to know, like, are you always going to send that person?
100% of the time, I offer and push gently towards therapy. I mentioned the other treatment options, which may be a mistake because sometimes they'll be interested in an injection at the same visit with me.
Yeah.
I always suggest therapy.
I try not to put needles in people the first time I meet them if I can avoid it, because our needles tend to hurt. But I will mention it, like Chuck, and sometimes, they take you up on it. If I have a hand therapist in clinic with me, and usually in that clinic I do, I will say, why don't you talk to so-and-so, either usually in the South County clinic, it's Kathy or Jamie, say, talk to Kathy or Jamie. They'll determine how frequently you might need to come for some therapy. Or if you're in clinic with me down at the main campus, talk to Macy, let's see what she thinks. And we're very fortunate to have that environment where we can do that, and it's not automatically a prescription. And like you said, for some of our patients, transportation resources are a challenge. And insurance stuff is a reality, and that can be very tough.
Let's pivot for the last few minutes, if that's okay, and let's just talk about post-operatively. First of all, Macy, what is your favorite CMC surgery to help a patient with post-operatively? Do you have a preference? Is it the standard LRTI? Is it the internal brace? Is it another procedure? Do you have a favorite, or do you feel like they all recover about the same?
I think this goes back to my gender point. I think if it's a guy, I like the internal brace reconstruction. I feel like they come out of that post-op dressing just rock solid. They got a really good posture of their thumb. I just look at their thumb and I'm like, that's a good outcome. The CMC joint is nicely positioned. Their MP joint's flexed. They just look good. And they typically don't need a ton of therapy from me because they're pain-free. Their range is good. You can start strengthening early. Yeah, they do great. And again, anecdotally speaking, for a woman, I kind of feel like an LRTI because you're casted. Well, it depends on the provider, but typically for maybe 6 weeks. And so they just have a little bit more opportunity to stiffen up, and they don't come out of that post-operative dressing just kind of like unstable and weak and scared. They're just like rock solid in that nice thumb position. Again, with the LRTI, obviously you have a little bit more rehab to do regarding the wrist. Their wrist, it's a little bit more stiff and painful. But I think they're both very reliable, and it depends on the patient. Obviously, if it's a revision surgery, and I think that my mantra for this is less is more. I see so much more recurrence of pain or recurrence of a collapsed posture rather than stiffness. So if I had the opportunity to have a say in how long they were mobilized, I'm always going to be a little bit more conservative and have it longer because you can't go backwards. You can always work on motion and stiffness, but you can't tighten up that joint even more. I just hate to see somebody start moving too early.
It's an interesting point because there is no doubt the trend is earlier mobilization, even for LRTI. And the study out of Salt Lake City by Hutch and others really described that, and they compared 2 weeks versus 4 weeks, and they got the same results. But I'm with you. I mean, I don't find any harm in immobilizing a little longer with a soft tissue reconstruction.
Exactly. What's the harm in it? It's just very rare that I would see somebody that gets too stiff. And sometimes there are those cases where you can tell they might have a little bit of a CRPS vibe or a lot of anxiety about a cast, or that they're super swollen, their fingers are stiff. Likely a good idea to get them started a little early, take them out of a cast, put them in a custom brace that they can take off to breathe. But obviously it's a very case-by-case basis.
And when you educate LRTI patients, how long do you believe, and it may not be a fair question because I don't know if you see them long enough, but how long do you tell them it's going to take them to get over the surgery and get back to a situation where they're not thinking about their thumb? So really get over it.
8 to 10 weeks, I would say. Typically, strengthening isn't initiated until 10 to 12. Again, depends on the provider. Depends on how the patient's doing, but if you need a ballpark, I would say 10 to 12. Let me know if you disagree. But to get over it to where you're really just kind of living your life and not thinking too much about it, I feel like probably 8 to 6 weeks they meet you. They're freaked out. You make them a brace, teach them how to move, see them, I would say twice a week. By the 8-week point, you've met them probably 6 times and they're getting a little bit more confident. They're not thinking about it as much. They probably have full motion, maybe starting to do some light activities without the brace on. Life's just a little bit better for them.
Chris, what do you tell them for LRTI till they stop thinking about it daily?
6 months. I used to tell them 3 months, and then we had Jeff Steppen, one of our former fellows and now superstar faculty, University of Chicago. He did a qualitative project interviewing patients who had thumb CMC surgeries. And they all said, and a lot of these were my patients, so I took this pretty personally, that we told them it was that the recovery was shorter than it actually was. So I tell them that it's going to take 6 months until they start to feel like, they don't hate me every time they use their thumb. But eventually they will get there. And I'd love it. I don't know, Macy, is it 10 to 12 weeks from when they start therapy, or is it 10 to 12 weeks from surgery?
10 to 12 weeks from surgery, being able to do some like resistance type thing. So like actually pulling your pants up with your thumb and index finger, like that kind of thing.
Got it.
So that's when life gets a little bit easier because they're allowed to use it. It's a different story if they have recurrent pain. So we obviously shared very different timelines, but I think it depends on what exactly we're talking about here.
I'd rather under promise, is I guess is the term for this.
Yeah.
But I mean, you also don't want, when you talk to patients about this, you have to be very careful because you don't want to overpromise. You don't want to underpromise because you also don't want to scare them away from what is a good surgery that can help a lot of people. But there are just some people that are on the fence, reasonably so, about surgery, and the amount of time it's going to take. But that number seems to have worked for me recently. Chuck, do you tell them something somewhere in between? You're closer to Macy, closer to my number?
I say 4 to 5 months. But what I'm telling them is, my thing is 4 to 5 months until you are back doing all your activities and you're not thinking about your thumb. I think at 8 to 10 weeks, people are back to most of their activities, but they are still thinking about that thumb. It's like
that's a good point.
It's like, to me, it's like any painful situation. You can start using the painful joint or the injured joint sooner, but it's really when they aren't thinking about it that means they're over the hump. So it's just definitions. I think we're all saying the same.
I agree.
How about golf? I've had some patients recently, obviously with the time of the year, asking about golf.
With an internal brace, I'll let them start pitching and putting at 5 to 6 weeks and progress as tolerated from there. I honestly think it's like 10 to 12 weeks before they're getting out the big driver and going crazy.
Macy, I want to ask one more question about this because it's a surgery that in the right situation works incredibly well, but it's not universally used. What about a CMC arthrodesis?
They do great. It depends on the right patient. Anecdotally speaking, again, I feel like the classic patient would be like a 40 or 50-year-old guy or woman who are a little bit too young for the more reconstructive procedures. Rarely do I have a complaint. It's like slam dunk. Pain is a 0. I have strength. I'm good. The only complaint I would say is if like the thumb was brought out too far into palmar abduction where it's a little bit in the way. But other than that, from a pain perspective and a function perspective, I think that they do quite well.
I'm a fan too. I think you know that, Chris. I don't remember the last time I did one, but in a young patient with high demands, I really like it. I think it can really provide a good outcome. And certainly, I just see a very young population that sometimes can benefit from it.
I think that procedure has gotten a bad rap, mainly because of that RCT that was stopped prematurely in Europe because of the high non-union rates. But radiographic non-union does not necessarily equate to a symptomatic non-union, and I think that was the experience that I think it was KJ Hippensteel, one of our residents, who wrote that paper with Dr. Gelberman and some of the other partners. The non-union rate is real. Now the symptomatic non-union rate was quite low. So I think with some changes in the technique and some of the newer implants specifically designed for that arthrodesis, it's a surgery that works really well. And I don't use one of the special implants, but I love that surgery in the right patient.
Yeah, totally agree. All right, Macy, final thoughts on your favorite joint in the body.
I guess my final thought would be to remember that less is more in a post-op patient, and in a conservative management patient, you just have to approach it in the right way. Doesn't require a ton of therapy, just give them a really good education session, and got to find the right patient. And yeah, that would be it. I appreciate y'all having me tonight.
Oh, the pleasure is ours. This will be a highly rated episode for sure. I've learned, as I always do when we chat, and we'll have to figure out the next topic to dive deep on.
Sounds great. Like,
questions for
I was-
Macy, handpodcast@gmail.com. Send them to Macy. Attention, Macy.
All right, y'all all have a great night, and we'll see you soon.
Good night.